So far, we've covered the epidemiology and risk factors for breast cancer, as well as diagnosis and treatment. In this section, we're going to cover the prevention of breast cancer, which includes both primary and secondary prevention of the disease. Good breast cancer outcomes are dependent not only on accurate diagnosis and appropriate treatment, but also on a third principle which we have not yet discussed, and that is early detection and screening. These three pillars together can ultimately lead to a decreased mortality rate. Part of prevention and early detection is educating patients about their own risks and instituting good screening protocols for those who are high risk. I showed this slide previously, and I believe it is an easy way for us to talk to patients about risk, highlighting for each patients which factors are within their control and which are not. Once an individual's risk is known, how should they be protected? It is known that screening for breast cancer saves lives. There are many forms of screening, but the best and most validated include exam-based screening and radiographic-based screening. Exam-based screening includes both self and clinical breast exam, while radiographic methods include mammography, ultrasound, and MRI. Breast self-exam and clinical breast exam are what is known as primary preventative methods. While breast self-exam has limited data on efficacy, it is a rational approach as it is free, painless, and easy to practice. Additionally, BSC will continue to be an important tool in settings where there is limited access to radiographic screening, but they have a high disease burden. This slide demonstrates appropriate technique for self-examination of the breast, though in general, self-breast awareness teaching is also acceptable. This method should be taught along with the previously mentioned risk factors, as well as the signs and symptoms of breast cancer to each patient. Another method of exam is that done by the practitioners, and that is clinical breast exam. Clinical breast exam can be done by several levels of practitioner, including the trained community health worker. It can detect over 50% of the same cancers that are detected by mammography, showing that it can be a powerful tool in both early detection when it is performed properly. Secondary prevention includes all radiographic methods done on a healthy population. Mammography has the most proven benefit, but some question its utility in low and middle income countries where breast cancer may affect a young population that has a shorter life expectancy and has other competing causes of death. Ultrasound is generally used as an adjunct to mammography. However, it may be a better tool in low and middle income countries as it is cheaper, faster, and requires less trained personnel. At this time, mammography continues to be the gold standard for screening by imaging. Mammography clinical trials randomize healthy women to mammogram or to usual medical care. And what those clinical trials found is that there was a 20 to 30% reduction in mortality due to screening mammography. However, screening benefits require the availability of diagnostic and treatment services. There are three types of mammography, which include film, digital, and tomosynthesis. I believe that digital is now widely available, although many places in the United States are now moving towards 3D tomosynthesis, which has better ramifications in terms of cancer diagnosis. Ultrasound alone has not yet been evaluated in randomized controlled trials of breast cancer screening. As mentioned, it has mostly been used as an adjunct to mammography in women with dense breasts. It is best used in the diagnostic workup rather than the screening side once an abnormality is identified on physical or by mammography. And lastly, a quick word about MRI. Its use in screening should be reserved for those patients who have high risk defined as a lifetime cancer risk of 20% or greater. There is no data currently that support its use as a population-based screening tool for those who have average risk. So these are the American Cancer Society screening recommendations for 2015 that state that mammography should be done annually starting at age 40 and should be continued without an upper age limit as long as the woman is in good health. Clinical breast exams should be done every 3 years between the ages of 20 to 39 and then annually. Breast self-exam is recommended beginning at age 20. And finally, MRI should be added to annual mammography for women with a high lifetime risk. So in summary for this section on prevention, let us recall that there are two main categories of risk for breast cancer that we can educate our patients about, and those include modifiable risk factors and those that are not. We should assess each patient's individual risk and then encourage both breast self-exam and awareness. Practitioners should be performing CBE and then add additional screening strategies as necessary and when available.